Καλησπέρα και καλή χρονιά. Θα έχουμε τη χαρά να ακούσουμε την ομιλία του Richard Spaide, που είναι ένας από τους πιο γνωστούς οφθαλμιάτρους που ασχολούνται με τον αμφιβληστροειδή παγκοσμίως. Ήταν από τους πρώτους που έχει ανακαλύψει τον αυτοφθορισμό και επίσης και το OCT αγγιογραφία για την μελέτη του χοροειδούς. Έχει πάνω από 300 δημοσιεύσεις και έχει πάρει βραβεία πολύ επώνυμα και γνωστά, όπως το Senior Honor Award από το American Society of Retinal Surgeons, από το American Academy of Ophthalmology, το Simon Gratz Award, το Koskas Award, το George Theodosiadis Award και το πιο γνωστό είναι το Richard A. Johnson Macular Degeneration Award, το οποίο είναι από τα πιο γνωστά awards που δίνονται στην Αμερική. Ήταν στο παρελθόν Executive Director of το American Journal of Ophthalmology και τώρα είναι Associate Director από το περιοδικό Retina, όπως επίσης είναι και στο Editorial Board πολλών περιοδικών. Ας ακούσουμε λοιπόν την ομιλία του Richard Spaide.
Thank you for the opportunity to speak. This talk is Beyond Pachychoroid. My name is Richard Spaide. These are my disclosures. The great biologist George Cuvier invented paleontology and also created a classification system for animals. He thought that elephants, hippopotamuses, horses, and hogs were all related because they had a thick skin. Now, as it turns out, they actually weren't related. They don't have a common ancestor. So the idea of thick skin or pachydermata as a class of animals was dropped. The choroid was found to be thick in central serous chorioretinopathy using EDI OCT. This included fellow eyes of unilateral cases of central serous chorioretinopathy and Vogt-Koyanagi-Harada disease. Well, pachy means thick, choroid means choroid, so the term pachychoroid was developed to mean thick choroid. And this included a number of diseases. But for some reason or another, it did not include Vogt-Koyanagi-Harada disease. Pachychoroid was a condition unto itself. It was also part of a spectrum. I wanted to learn more about this, so I looked at all of the papers on PubMed published from September 2013 until April 2020. Specifically about pachychoroid, there was no definition in 19 of the papers. There's increased choroidal thickness combined with some kind of modifier like dilated veins or history of central serous in 6 papers. There's a specified choroidal thickness, such being greater than 200 microns, greater than 220 microns thick, 270, 300 as you see on this list. Those are 14 papers in that class. Now these also included some modifiers like or extrafoveal thickness greater than 50 microns and choroidal vascular hypermobility, that sort of thing. And finally, there was some just based on appearance, and some had to have directly visible pachyvessels, or on the other hand, reduced fundus tessellation. There were 5 in that. So altogether, for pachychoroid, there are 44 papers. 19 papers had no definition at all. 25 papers had 18 different definitions. What about a choroid thickness of 200 or 300 microns thick? Here's a list of choroidal thicknesses in different age groups. And you can see that in children, for instance, the mean choroidal thickness is well over 300 microns, even if they're myopic. Even among patients people in their 30s, their expected mean choroidal thickness is greater than 300 microns. In larger groups of patients with older mean age, you can see that the choroidal thickness dips down just below 300 microns. But that only happened when the patients were in their mid-40s. So then what about a cutoff of 300 microns or 270 or 220 or 200 microns? All of those are essentially normal choroidal thicknesses. They're not thick choroids. If we accept them as being a definition for a disease, that would mean most people in this meeting have pachychoroid. There's another aspect of pachychoroid. Those are pachyvessels. Pachy means thick. Vessels means vessels, so pachyvessels means thick vessels. There again, I looked at all the papers involving pachyvessels. 7 of those papers had no definition. 4 papers had something simple like dilated Haller's vessels. There are more complex definitions which specified the vessel thickness or diameter, and they also include some modifiers such as end choriocapillaris attenuation or end Sattler's and choriocapillaris attenuation. So there are 22 papers about pachyvessels, 7 papers had no definitions, 4 papers had simple definition, and 11 papers had 7 different kinds of complex definitions. What about choriocapillaris attenuation? That's one aspect of pachychoroid and of pachyvessels. The idea that the choriocapillaris is thin or attenuated on OCT. Well, as it turns out, by histology, the choriocapillaris thickness ranges from 4.4 to 9.8 micrometers. But we're using an instrument, OCT, that has a resolution that's maybe 5 to 7 microns. So it's really not possible to grade how thick something is if the resolution of your device is the same thing as what you're trying to measure. So it's really not possible to know if there's thinning of the choriocapillaris with current models of OCTs. What about other causes of thick choroid? I already mentioned Koyanagi-Hirata disease, for some reason or another, is not considered to be part of pachychoroid. And if you can't explain that, then it's going to be hard to explain this list of different conditions that's not considered to be pachychoroid, or this extension on that, which is also things that cause a thick choroid. How about this other list of things that cause thick choroid? As you can see, there's about 24 different entities that cause a thick choroid that for some reason or another are not considered to be pachychoroid diseases. Well, the definition of pachychoroid was expanded, and then people said, well, the choroid doesn't have to be thick to be pachychoroid, even though pachychoroid means thick choroid. But they said choroidal vascular hyperpermeability is important. If so, then what about these causes of choroidal vascular hyperpermeability? Why aren't they considered to be in the pachychoroid spectrum? Or these? Or how about these entities? They all cause choroidal vascular hyperpermeability, but are for some reason or another not included in the pachychoroid spectrum. So pachychoroid spectrum is really an incomplete and poorly defined entity. It lacks the thematic focus, particularly since it no longer means they have to have a thick choroid. It is a spectrum if most of the diseases that could be in the spectrum are not included, and it's arbitrary which ones are actually included. So I don't think it's a very useful term, and it may come to be used something like white dot syndrome or pachyderm from George Cuvier. Central serous chorioretinopathy is an important disease, though, and it has many defined and undefined characteristics, but it does seem to define a particular pathology or pathophysiology in the choroid that some other diseases also seem to share. So I think it's worthwhile to go back to central serous and start again and to look at that disease and see if we can understand it and then group diseases based on this new understanding that we may be able to obtain. First, I'd like to talk about a few different concepts. One is fractal branching. We're used to the idea of fractals in which there's cell similarity across units of scale. This is the Amazon River Basin, and you can see that how the branches all kind of look like each other. And this is a common thing for rivers to have a fractal aspect to them. Bronchioles are arranged on a fractal sort of basis. Blood vessels, including retinal blood vessels, are arranged in a similar basis. So the retina actually has been studied, and there's even entire books written about the fractal nature of the retina, retinal blood vessels. But let's look at the choroid. The choroid does not seem to have such a fractal pattern. Each blood vessel that you see is essentially a vein. It drains a few choriocapillaris lobules, and then the vein continues unchanged in size until it reaches the ampulla of the vortex vein. It's a very unusual sort of arrangement of blood vessels. There are hundreds of vortex vein vessels. They don't really combine with each other. Ordinarily, you would expect them to all combine into only a few large veins, but they don't do that. This is an ordinary fractal pattern of a tree that I took outside of my house. It has an expected fractal pattern for branches. This is a baobab tree which grows in an area that's subject to droughts. The curious thing is it doesn't really have the fractal pattern that we expect the tree to have. The top few branches maybe has a fractal pattern, but after that it just has one long column of the trunk. As it turns out, that trunk has a different duty than just a regular tree trunk would have. This trunk apparently can store up to 4,000 liters of water, so that during a drought the tree can stay alive. So the fractal pattern of the baobab tree deviates from a pure fractal pattern because there's another function that tree is trying to optimize. If you look at a baobab tree, it is kind of like any one of these choroidal blood vessels. At the tips of the blood vessels, maybe there's a fractal pattern, but the long trunk of the blood vessel must have a different function than just an ordinary blood vessel would have. So there's lots of blood vessels inside the eye, in the choroid, and they probably have some other functions. So we could try to think about what those functions could be. So the baobab tree has its fractal geometry changed because of additional functions. And the same thing is probably true for vortex veins. The fractal geometry of vortex veins is not preserved in the same way because maybe of the different functions. So these additional functions could be to act like a heat sink. The retina is very highly, is metabolically very active and produces a lot of heat, and that heat needs to be removed. Another thing is that those blood vessels may act as a reserve for oxygen storage inside of the eye. The third thing, and maybe the most likely, is that it helps modulate pulse pressure inside the eye. The eye and the brain are quite similar in a sense. The brain is contained within a skull, which limits expansion during the pulse of pressure going inside of the brain. The brain uses about 25% of the blood supply of the body. But the brain is very sensitive to pressure, so there's mechanisms inside the brain to help modulate pressure. And one of those is storage of venous blood in the brain that gets released when the pulse of blood comes in systole. Let's look at the eye, which is somewhat similar to the brain in a sense, in that the eye has a hard shell on the outside that resists deformation, and the eye has a fairly high blood flow rate. The blood comes in to the choroid at approximately 70% of systemic blood pressure. If you measure the blood pressure in a choroidal vein, it's about 2 or 3 millimeters more than the intraocular pressure. The pressure in the vortex veins is only a few millimeters of mercury. Since the pressure in the choroidal vein is only a few millimeters higher than the intraocular pressure, you would expect that if you increase the intraocular pressure, the choroidal vein should collapse. That's not actually what happens. If we increase the intraocular pressure, the pressure in the vortex veins still remains at a few millimeters of mercury. The pressure in the choroidal vein remains 2 to 3 millimeters more than intraocular pressure. And that's true over an extremely wide range of pressure inside the eye. Here's a graph showing how you can change the pressure inside of the eye and then measure the pressure inside of choroidal blood vessels. And you can see that the choroidal blood vessels continue to increase their pressure so that they're just above the intraocular pressure all the way up to systolic blood pressure of the animal. At that point, the blood coming out of the vortex vein stops. This appears to be an entirely passive mechanism by which the blood supply, or the blood leaving the eye, is passively controlled by the pressure inside of the eye. This defines something that's called a Starling resistor. So a Starling resistor has a sort of a variable resistance of outflow, and it's entirely passive. And at least for the eye, this seems to be localized at where the vortex vein ampulla leaves the eye as the vortex vein. This is a little bit complicated. I'm not used to talking about blood flow leaving the eye as being complex or controlled by anything. I've written a review article about this, about choroidal blood flow, and the explanation for the vortex vein system. It's available online through Retina. So Starling resistor is actually used all around the body. This is just a passive way that that fluid can be controlled through a pipe. It's not necessarily passive, it can also be active as well. But venous drainage from the brain acts through a Starling resistor, as do birds singing, snoring, or obstructive sleep apnea works by a Starling resistor, as do the sounds that we listen to when we're measuring blood pressure. The pressure flow relationships in Henle's loops work by a Starling resistor, and the control of urine flow in the urethra also works through a Starling resistor. So they're commonly used all around the body, and it looks like the venous control in the eye, is particularly in the choroid, is an important thing. Again, here's that article. So next, let's look at what happens in central serous and allied diseases and try to make some kind of theory that would help explain these findings. Ordinarily, the vortex vein systems are completely separated from each other and they do not communicate. Generally, there's 4 per eye, and you can see that the white line separates the medial and lateral vortex veins, and the yellow is the watershed zone between the superior and inferior ones. Usually they meet together at right angles. In some people, they're not right angles. But the point is that each one of these systems is generally fairly independent of the other. And this has been shown by Hayray to be true in monkeys as well. Here's a patient with central serous. Notice that this patient, it would be hard to make a drawing like I showed you before about looking where the watershed zones are, because there's big blood vessels that cross over and anastomose between each one of these vortex vein systems. Here's another patient with central serous. Note the large intervortex venous anastomoses that exist in this disease. In fact, every patient we looked at with central serous has these vortex vein anastomosis. It's a kind of unusual aspect of the disease. Here's another patient with central serous. Look at the large size of those intervortex venous anastomoses. These are like giant varicose veins in the choroid. I think, I can't be sure, because there's so many different definitions for pachyvessels, that if we did an OCT across the macula and looked at those big vessels, we would think those were pachyvessels. Peripapillary pachychoroid syndrome is defined as intraretinal or subretinal fluid in the nasal macular region and a thicker choroid in the nasal macula than would be expected for the person's age. Now, you could see there's probably 15 diseases that meet that definition, but what they were looking at, or what they're talking about, was this condition here. And here's again a wide angle ICG taken with an Optos. And look at the blood vessels that are in this patient. Can you find a watershed zone in this patient? The answer is no. Look at the amazing number of intervortex venous anastomoses that are present. And I've outlined just some of them in yellow. There's many of these, as you can tell. We can take a closer look at this. And again, look at how the intervortex venous anastomoses surround the optic nerve head. And that's why the choroid in these patients, I believe, is thicker than you'd expect, and why you would see large blood vessels on B-scan. It's because there's an amazing number of anastomotic vessels there. Here's another patient. This is taken a little bit later in the angiogram. There's so many of these blood vessels, it's even hard to see them as separate entities. And again, here's another patient with peripapillary pachychoroid syndrome, large number of anastomotic blood vessels. I looked at patients who had, again, this is central serous. These vortex anastomosis occurred pretty much in the central macular region, and peripapillary pachychoroid syndrome, they occurred around the nerve. And I think these blood vessels are what people thought were pachyvessels. Now some of these patients go on to have neovascularization. Look at this patient. The arrow points where the neovascularization is, and you can see these giant anastomotic blood vessels connecting the vortex veins. In fact, it's hard to see in a normal choroidal blood vessel here. They're all just giant anastomotic vessels. These things are like varicose veins in your choroid. Here's another patient. Again, these are like varicose veins in the choroid. And this patient has neovascularization. It's kind of a little bit harder to see on a slide, but it's where the arrow points. You can imagine that the venous pressure inside the choroid in this patient with the varicose veins of the choroid, this inter-vortex anastomotic vessels that we're seeing, is very high and puts back pressure on the chorea capillaris. This could cause the chorea capillaris to leak, causing the hyperpermeability that we see in central serous and its associated disorders. And you can imagine this could cause damage to the chorea capillaris, resulting in ischemic changes and secondary neovascularization. So there's not many veins. They're all giant anastomotic blood vessels. Here's a patient who had central serous who went on to have polypoidal choroidal vasculopathy. Same thing, this patient had big anastomotic blood vessels. And here's yet another patient with polypoidal following central serous, and she also had these anastomotic blood vessels. So in neovascularization, both regular neovascularization and with polypoidal, the anastomotic blood vessels often were large, and the pattern was similar to that in central serous eyes, which is understandable given there were central serous eyes to begin with. There's other important work that fits into this. Hidetaka Matsumoto and Dr. Kishi looked at OCT slabs, and they thought they found pretty much the same thing. Now, they didn't look at over a wide field, but they thought that these patients had, in this case neovascularization, that these patients had anastomotic connections between the supratemporal and infratemporal vortex vein systems. Because they only looked at 12 by 12 images, they couldn't tell about the wide range of anastomotic blood vessels that are present, but they're still barking up the same tree. Hideki Koizumi and Japan looked at the thickness of the sclera in central serous patients, and he couldn't look at the posterior sclera, but he could look at the anterior sclera. And they found that patients with central serous had thicker sclera than patients who didn't have central serous. So putting this all together, it appears that patients with central serous have these large anastomotic blood vessels. They're almost like vortex, like varicose veins of the choroid. And for them to be that large, you would expect that there would be a high level of pressure, and that the pressure management in the venous system in the eye would not be correct as compared to a normal configuration that we discussed earlier. This high pressure would cause the leakage inside the choroid. Now, in a normal sclera, some of that fluid can leak out posteriorly through the sclera. Remember, there's no lymphatic system inside the choroid. However, if you had a thick sclera, less fluid would be able to leak out. So a patient with central serous is more likely to make fluid inside the choroid, and the fluid has a more difficult time leaving through the sclera. The only place you would expect then the fluid to manifest itself is by pigment epithelial detachments and retinal detachments as well. So central serous has an abnormal venous structure. There's large anastomotic blood vessels that look like varicose veins. These may increase the backloading of pressure into the chorea capillaris. There's a potential outflow abnormalities caused by these large varicose veins in terms of how that Starling resistor works. There's choroidovascular hyperpermeability and decreased permeability of the posterior sclera, leading to accumulation of fluid. So central serous chorioretinopathy can cause fluid accumulation to choroid, the sub-RP space, and the subretinal space. There's chorea capillaris damage, as we know, and eventually RP damage and atrophy. So the new ideas in this talk are that pachychoroid is an inaccurate disease concept. There's many different definitions for what pachychoroid is and all of its subsidiary components. These definitions are all independent. They change from one author to the next. In fact, change even in one author to one paper to the next. There are many things that are left out of pachychoroid, and it seems arbitrary what was included. I think it's worthwhile to look back at central serous. There are some mechanisms of the disease that are becoming clear, and we have several papers that are coming out about central serous and related diseases that highlight some of the pathophysiology of what's going on. And with that, I thank you for your attention.
Ευχαριστούμε τον κύριο Σπέιδη για την ωραία ομιλία. Νομίζω ότι δεν ξέρω αν υπάρχουν ερωτήσεις. Αυτά μπορούμε να κλείσουμε.